التي تخص البيدياتريك كاتاراكت سيرجري. هذه السيشن بتحتوي على أولا عنوانها Challenging Pediatric Cataract Cases, and the participants are 4 participants. الأستاذة الدكتورة نهال الشقنقيري، أستاذة جراحة العيون جامعة اسكندرية ورئيسة قسم جراحة عيون الأطفال هناك، والأستاذة الدكتورة دينا الفيومي، والأستاذة الدكتورة رشا زيدان من جامعة القاهرة، كلية طب جامعة القاهرة، ومستشفى الأطفال أبو ريش قسم طب وجراحة العيون. هنطلب من الدكتورة نهال أنها تتفضل، وأرجو من السبيكرز ان هم يلتزموا بالتعليمات اللي سبقنا الدكتور احمد مصطفى، ان كل واحد لينا له 13 minutes.
It's a great pleasure and honor to participate in this meeting. I'm going to speak about management of persistent fetal vasculature in children. Dealing with congenital cataract in children, sometimes it is not simple congenital cataract. It may be associated with other pathologies as persistent fetal vasculature. The hyaloid artery starts during intrauterine life, proceeding forward, giving posterior tunica vasculosa lentis, then laterally, and then anterior tunica vasculosa lentis. At birth, this vasculature is rudimentary and is not present. If any part of this vasculature persists, this is called persistent fetal vasculature. So, if anterior tunica vasculosa lentis is present at birth, this is called persistent papillary membrane. If the whole posterior tunica vasculosa lentis is present, this will clinically be termed persistent posterior fibrovascular sheath of the lens. If only the anterior stump of the hyaloid artery, this is going to be called Mittendorf dot. If the whole hyaloid artery is present, this will be the persistent hyaloid artery. And if only the posterior part of the hyaloid artery is present, this is going to be termed clinically Burmester papilla. So the first type is persistent papillary membrane. This is the normal feature of the iris and the pupil and the collarette, and usually emerge at the level of the collarette. Persistent papillary membrane may affect vision or not. It may be adherent to the lens surface or may be non-adherent. The extent of this persistent papillary membrane of the may be so minimal like that. It may be mild, it may be moderate, or may be severe. It may be adherent to the anterior surface, as I told you, like that. And it may be associated with a fibrous ring that is adherent to the anterior surface of the lens. And this fibrous ring may be total, including the papillary axis, or may be partial, like that. And surgery is indicated in these membranes if it is associated with a total fibrotic ring, including the visual axis and preventing good refraction, or if it is non-adherent and totally, again, occlude the papillary axis, or if it is adherent and occlude the visual axis when the pupil is constricted. Surgery is very simple. It's just عبارة عن peeling off the membrane off the surface. During surgery, 2 wounds are opened with MVR nymph like that, 20 gauge, and then with the micro scissors, we cut the strands 360 degrees, and then the adherent part with a special forceps, it is peeled off the anterior surface of the lens, and here at conclusion of surgery, and finally we close the wounds. Even if the adherent part is extensive like this, still after cutting the membrane, it can be again peeled off easily the anterior surface of the lens, and here at conclusion of surgery. And these are some examples before and after surgery. Here, an adherent membrane before and after clearing the visual axis, extensive membrane before and after surgery with a fibrotic ring. Here, after clearing the visual axis, and the pupil can be easily dilated and refraction can be done. And majority of these cases are associated with high hyperopia. But sometimes the membrane is fibrotic, and it totally occludes the visual axis when in bright light. And even if it is fibrotic, again, we can peel it off the anterior surface to clear the visual axis, and here after surgery, and here before and after clearing the visual axis. The second type of persistent feeder vasculature is Middendorf dot. This is the anterior stump of the hyaloid artery. It's usually a very small spot of opacity, and you see here that there is the hyaloid artery moving, and it doesn't affect vision, and usually it doesn't require any treatment. The third type of persistent feeder vasculature is posterior fibrovascular sheath of the lens. Usually it presents as a fibrovascular membrane related to the back surface of the lens. It may affect sectorally the lens like that, or may involve the whole posterior capsule. It's usually associated with a variable degree of prominence of the ciliary processes. It may be mild, moderate, vascularization that may be mild, moderate vascularization, or severe vascularization of the membrane. And it may be affected with a variable degree of ciliary processes prominence, as a mild prominence, or moderate or severe prominence of the ciliary processes. During surgery, after irrigation aspiration, we cut the membrane and then we eat it up with a cutter. We used to do this in the past. This is not enough, because if we leave the visual axis cleared like this, but without cutting the membrane radially, this going to lead to capsular phimosis that pulls centrally over the ciliary processes, leading to atrophy of bulbi in the future. So in these cases, after cutting the membrane and after eating up with a cutter and performing anterior vitrectomy, we have to go with radial cuts of this fibrous ring to prevent capsular phimosis in the future, and it's going to be a capsular support for future secondary IOL implantation when needed in the sulcus. And here, at time of secondary IOL implantation, can you see the fibrous ring, and here the ciliary processes, and here after implantation of the secondary IOL, and here after surgery, the IOL is beautifully centralized, supported by the fibrous ring and the ciliary processes. And even in cases with high vascularization like that, during surgery, we can use intraocular diathermy in these cases. And after eating up the membrane, again, we cannot leave this capsular ring like that. We cut it in all quadrants by micro scissors, but take care never to go towards the periphery. Otherwise, it will retract, and you're going to lose this capsular support, preventing you from secondary IOL implantation in the future. But on the other hand, sometimes there is a very minimal ciliary processes prominence like that, and the membrane is totally fibrotic without vascularization. Now it's a simple surgery. We cut, we eat up, and we enlarge carefully for secondary IOL implantation. And here, 10 years after surgery with secondary IOL implantation in a child, can you see here, these are the prominent ciliary processes, and this is the child 10 years after surgery having in secondary IOL with clear visual axis and straight eyes. Sometimes the membrane is only vascularized, no fibrosis, only vasculature like that. During surgery, after irrigation aspiration, look here to the blood vessel. Here it is empty, and you can see the blood trickling here in the blood vessel. Still, we can perform posterior capsulorhexis by hooking, tenting, tearing, and then injection of viscoelastic into the Berger space, and then performance of the posterior capsulorhexis totally separable from the vasculature. And then eat up the vitreous and the vasculature. We have now a beautiful capsular bag where we can inject the IOL between the anterior and posterior rhexis. And if the membrane is extensive, we can remove the whole posterior capsule and perform optic capture technique, as in this baby. But sometimes there is association between anterior and posterior tunica vasculosa lentis, as in these cases. Still in these cases, we can clear the visual axis and leave the eye aphakics, or in some cases, we can use iris retractor, perform the capsulectomy, radial tears, and primary IOL implantation. And some cases are associated with extensive, different morphologies and abnormality in the shape of the lens, even corabomatous lens. Again, these cases after irrigation aspiration, clearing the visual axis, or we can even implant intraocular lens. And here at the site of, there is a keratolenticcular adhesion ودي مكان الcleavage between the lens and the cornea. And this is another case, clearing the visual axis, and here at time of secondary IOL implantation, we cannot cut or remove this, otherwise we're going to lose the capsular support. So we cut the fibrotic ring, and then we implant the IOL in sulcus, and here 3 years after secondary IOL implantation. Another case, despite extensive pathology, but we have clear visual axis. The fourth type is persistent hyaloid artery, extending from the optic nerve to the back surface of the cornea. It presents with a posterior polar opacity related to the back surface of the lens, and here you can see the hyaloid artery, or causing irregularities in the posterior capsule, causing very high astigmatism, or causing associated with a congenital cataract imitating ectopia lentis, and sometimes presenting with total cataract with a total posterior capsule opacification. The hyaloid artery stump may be variable in size, mild, moderate, or severe, thickened, and sometimes associated with prominence in the ciliary processes like that. We perform red cam to see the extent of the pathology affecting the optic nerve and the affection of the macular area if it is involved. We don't operate when the macular area is affected. And in dense cases, we perform ultrasound and we can judge. The hyaloid artery may be thin, maybe moderately thick, or maybe extensively thick and associated even with thickening of the retina, and sometimes so severe that an MRI is needed to confirm the diagnosis. Sometimes there is retrolenticular fibrosis that is mild or severe. And sometimes we have to go for a UBM to see the extent of the retrolenticular fibrosis in order to exclude surgery when it is very dense. Some cases are associated with a congenital tinted shaped retinal detachment that if involved the macular area, we don't perform the surgery. Some cases have a normal corneal diameter and others have microcornea. Some cases have a normal axial length and other associated with severe microphthalmia like that. We are very selective in these cases. We perform only cases with a normal corneal diameter. We don't perform less than 10 millimeters, with normal axial length, with thin stalks or moderately thick stalks. We don't operate on severe microphthalmia or extensive fibrosis like that. They will not benefit from surgery. And we don't operate cases associated with tractional retinal detachment involving the macular area. And during surgery, after irrigation aspiration, we can perform the posterior capsulorhexis totally inseparable of the anterior vitreous face, and then anterior vitrectomy. And here, now it's a simple case where we can implant the IOL inside the capsular bag. And in cases where the posterior capsule is aggressively involved, we remove the whole posterior capsule. We perform the vitrectomy. We have a beautiful capsular support where we can implant the IOL in sulcus and perform optic capture technique. And here how it appears after surgery. And in cases of a total posterior capsule, we cut the posterior capsule and perform the vitrectomy and implant the IOL inside the capsular bag. And even when we have prominence like that of the ciliary processes, no problem, they don't bleed. In these cases, we clear the visual axis for secondary IOL implantation, or we implant directly in sulcus and perform optic capture technique. And this is the final case with a baby with persistent hyaloid artery after irrigation aspiration and cutting. And can you see here, just 1 minute, half a minute. During vitrectomy, you can see here the stump of the hyaloid artery. Here, after clearing the visual axis and then cutting with the radial tears at conclusion of surgery, here the baby immediately after surgery, and we wearing the aphakic spectacles, half waking hours and patching the normal eye, maintaining straight eyes along the months here and here after secondary IOL implantation, 4 years after surgery, still maintaining clear eyes and straight eyes, 10 years after surgery, still having straight eyes. Finally, to conclude, persistent fetal vasculature may present with a wide variety of clinical presentation, and some cases are operable and some are inoperable with poor visual prognosis. We have to be good selective for the cases in order to have good prognosis, and don't forget the amblyopia therapy, and thank you very much for your kind attention.
Bismillah ar-Rahman ar-Rahim. I'm honored today to be presented by my professor and my mentor, Dr. Mohammed Al-Sada, and I'm honored to be invited to join you today. My talk today is going to be on posterior lenticonus. We all know that it is a rare congenital lenticular anomaly that is characterized by a localized protrusion of the posterior lens capsule and cortex. Its exact etiology is still not known. There are many theories. Some postulate that it is maybe due to a posterior polar traction of the lens by a hyaloid artery remnant, or an aberrant hyperplasia of the posterior lens fibers, or a weakness of the posterior lens capsule. Most of the cases are unilateral and sporadic, but when we see bilateral cases, we must think of hereditary patterns, mainly autosomal dominant or autosomal recessive. Some cases also may be inherited as X-linked patterns, but in bilateral cases, we should always look for syndromes like Alport syndrome and oculocerebrorenal syndrome of Lowe's. In the diagnosis and the presentation of posterior lenticonus, early cases are usually presented by the localized oil droplet-shaped protrusion of the lens, which is typical for the diagnosis of the cases. Sometimes they present with refractive errors of lenticular origin, like myopia and a high degree of astigmatism. Then, plus or minus, a lenticular opacification starts to progress. Some cases present with a total lens opacity, and typically this lens opacity starts from the posterior pole and then extends to involve the lens cortex in the subcapsular area. Total cataracts have also been associated with posterior lenticonus, and these patients will present with leukocoria. So, when the patient presents with a dense cataract, identification of posterior lenticonus becomes difficult because there is no definite cone that could be seen by examination, and so we can unexpectedly discover this intraoperatively by finding a large posterior capsular opening. So, why is it important to identify posterior lenticonus preoperatively? Because if we don't do this, and the failure of recognition of such anomaly in the posterior capsule will lead that the surgeon proceed with the usual or the routine hydrodissection, which results in premature opening of the posterior capsule with a vitreous prolapse, incomplete removal of the lenticular matter, or even dropped lens material. So, in cases presenting with total cataract, we should proceed for an ultrasonography prior to the surgery with a special attention to how the posterior capsule look and the shape of the posterior capsule, which may indicate the presence of a pre-existing posterior lenticonus. However, this might not be present in all cases by ultrasonography. So there was a new sign described that was published in the Journal of Clinical and Experimental Ophthalmology in 2015, in which the authors said that they recognized a new sign for posterior lenticonus, in which the posterior cortical opacity appeared to be irregular in all the cases. And by this sign, they said that they suspected that the patient had a posterior lenticonus. When we manage such cases, we also, as I said, that knowing that we are dealing with a posterior lenticonus preoperatively is much better than discovering this intraoperatively. First step, when we go for our anterior capsular axis, we prefer that it should be a well-circumscribed, well-centralized, relatively a smaller one, and a continuous as much as we can, because by the end, if we succeed in achieving a good anterior capsular axis, this is a relief for the surgeon because I have a safe IOL, I will go for a safe IOL implantation regardless the defect which is present in the posterior capsule. When we go for the irrigation aspiration, surgeons advocate that we don't go for any hydrodissection in order to avoid the rupture of this thin posterior capsule. Some others advocate doing multiple small areas of hydrodissection, not reaching the edge of the suspected weak or absent capsule in order to facilitate removing of this sticky cortical material in the children. And the peripheral cortex is usually preferably removed first, leaving the central part till the end of the surgery as a scaffold to protect us from any preterm or premature opening of the posterior capsule. Then the central and the posterior cortex can be aspirated cautiously. Now we come to the posterior capsule. Either by the end of the surgery that we find an intact, thinned posterior capsule, or we find a pre-existing defect. A pre-existing defect that is variable in size, it might be small or a big defect, maybe central or even eccentric defect. As in this case, in the surgery, before the surgery, I could see the posterior bowing of the posterior capsule, and at the same time, after I removed the lenticular matter, the posterior capsular opening was extremely delineated exactly as it was present pre-operatively. When we come to the intraocular lens implantation, it is usually difficult in certain cases when the posterior capsular defect is large or eccentric to preserve the capsular bag for an in-bag implantation. So the eccentricity of the capsular defect from the posterior pole, as well as the size of this capsular defect, decides whether I'm going to implant the intraocular lens in the sulcus, or I'm going to put it in the bag, or I'm going to place the haptics in the sulcus and do a capture of the optic. However, by the end, inside the bag implantation is also a possible outcome if I still have a well centralized and a small capsular defect. The prognosis of posterior lenticonus is being, in most of the cases that are encountered are unilateral, so most of the cases usually suffer from amblyopia after the removal of the cataract. However, the visual prognosis of such cases is usually favorable, and the prognostic factors are unknown, but age at the diagnosis and the density of the presenting cataract remain the main two important factors for the prognosis of such cases. So, in order to conclude, we have to do a very careful examination of congenital cataract cases, especially the cases that are presenting with a total lens opacity, in order to be able to distinguish the cases with a posterior lenticonus. Early cases of posterior lenticonus that are evident with a slit lamp examination should also be detected. And in the cases where the cataract is very dense, that do not allow us to detect this posterior lenticonus, so we go for either looking for this sign of an ill-defined posterior, ill-defined edges of the posterior cortex, or doing an ultrasonography and looking for the shape of the posterior capsule. So recognition of these cases is very important for the proper management and for the optimal visual prognosis of such cases. Thank you.
Thank you, Dr. Dina, for a very interesting subject. This is a rare condition. عشان ما تعتقدوش ان انتوا بكره الصبح هتروحوا تلاقوا حاله لنتيكونس مستنيه. Condition, and unless you know of it, you discover it during surgery. Most of the time you're discovering during surgery when you're operating a case of congenital cataract. And when you discover it, it opens the posterior capsule. When the posterior capsule is opened, usually what happens انك تعتقد انك انت اللي فتحت البوستير كبسول تخلص الحالة وما انتش عارف ان ده posterior lenticonus. فدي من هنا أهمية this lecture. And it gives you an idea and there is something called posterior lenticonus, and you recognize it during surgery. It's very important عشان to safeguard the posterior capsule if you want to do a good implantation inside the back. The next speaker is Professor Dr. Rasha Zidan from Cairo University, and her topic is cataract in a uveitic child.
Thank you. Thank you, Dr. Seda, and thank you, Dr. Ahmed Mostafa, for giving me the chance and invitation today. I'm going to be talking about a rather difficult type of cataract seen in pediatric age group who have uveitis. But before we decide to perform the cataract in this age group, we have to ask ourselves, what are we trying to achieve? Are we trying to achieve a visual rehabilitation? And what is it that we are trying to avoid by performing cataract in these eyes? Our achievement, obviously, is a visual rehabilitation in this vulnerable age group, and at the same time maintaining an activity-free status of the eye. And we should always try to prevent our worst nightmare if this patient should end up with a ciliary detachment and phthisis bulbi. So the villains, as I like to call them, or the causative uveitic agents, most common is the juvenile idiopathic arthritis, Fuchs, Behcet, Vogt Koyanagi-Harada, toxoplasmosis, parasitic uveitis, and herpes simplex uveitis. The victims in the eye are the anterior and posterior synechia, band keratopathy, cataract, secondary glaucoma, cystoid macular edema, and optic atrophy. So before we jump in and decide to perform surgery for these children, we need to, first of all, assess their pre-existing systemic condition. Be sure that you're going to have intraoperative technical difficulties. There will be a dilemma about the IOL, whether you implant or not. And even if all goes well, second day you may have some unexpected post-operative responses. So which patients will benefit if we perform our cataract surgery? If we have an eye that's been quiet for a minimum of 3 months before performing the surgery, you performed your comprehensive systemic evaluation and you did a comprehensive ophthalmic assessment, then you have to exclude that the hindering of this vision is not due to the presence of just a band keratopathy, or that this patient is glaucomatous or hypotenuse, or is this a papillary membrane, or does the patient have a cyclitic membrane? And we cannot emphasize enough on the macula and the optic nerve, especially in this age group where it's very difficult to assess them, and therefore along the course of his uveitis you should have made an assessment of both the macula and the optic nerve. Investigations to help you along the way, of course, ultrasound to detect maybe a cyclitic membrane, or if this patient has a choroidal thickening or choroidal detachment. A UBM is also another diagnostic tool for detection of cyclitic membrane, the angle, the peripheral anterior synechia, and again, along the course of uveitis, not after you have developed a cataract, but you should have performed an OCT to detect if this patient has cystoid macular edema and an optic nerve, probably a cupping if this child, especially in an uncooperative child. So hypotony seems to be our enemy because hypotenuse eyes are poorly functioning eyes, and the flags that you may end up after surgery with hypotony are if you have a poorly controlled uveitis prehand, if you have a low intraocular pressure even though the eye is very quiet, if you have a seclusive pupillae and you have a normal intraocular pressure, if you have a phacodenesis but you don't have any evidence of zonulisis, and you have a diffusely thickened choroid or choroidal effusion on your ultrasound. The preoperative, perioperative, and postoperative preparations are crucial for these patients. I think that before we were all advised that prior to surgery we should give the patient topical steroids maybe 2 weeks maximum before attempting to do a cataract surgery, but actually it's quite more than that, because after controlling the systemic condition and the patient has no inflammatory activity, we still have to continue their immunosuppressive therapy and give oral corticosteroid prophylaxis 3 days prior to surgery at a dose of 0.5 milligram per kilogram body weight. If the patient is already on chronic oral steroids, then we will give a stress dose on the day that's to be tapered gradually post-operative. During surgery, we should not forget our systemic steroid, a subtenon steroid injection at the end of surgery, and patients who have posterior uveitis, have history of cystoid macular edema, or poorly controlled uveitis should receive intravitreal injections of steroid or may even require steroid implants. Again, the word and the drug of choice, the magic drug is steroids, so give intensive and strong topical and oral steroids post-operatively to counteract the possible exacerbation of inflammation. The surgical consideration. So now we're ready to perform our surgery. The cornea may hinder your visualization because of the band keratopathy. You have synechia, anterior and posterior synechia, which have to be dealt with carefully in order to perform your rhexis. And the pupil has many scenarios because of the presence of synechia and occlusio pupillae, seclusio pupillae. And in this age group, you may ask yourself, well, if it's a soft cataract and he's a young child and he doesn't have a nucleus, I can make a small opening, irrigation, aspiration, and I'm done. Actually, it's not that simple because you have to try to make a very good capsulorhexis and you have to try to maintain your bag in order to implant your IOL inside the bag. So in order to obtain pupil dilatation, you can either do it manually, inject intracameral adrenaline, use iris hooks, pupil dilatation rings, or even multiple small sphincterotomies. The iris is atrophic, maybe floppy, you may get hyphema or bleeding during your surgery. The cataract is not the simple cataract that you're used to. The capsule may be tough and fibrotic, the lens may be partially absorbed, and there may be phacogenesis. The IOL dilemma. Obviously, we all ask ourselves whether to implant or not, but actually it begins rather early on because performing your biometry may give you fallacies because a band keratopathy will make K readings inaccurate. You may have anterior and posterior synechia, so your anterior chamber depth is inaccurate. You have hypotony or epiretinal membrane, so axial length is inaccurate. And then you ask yourself, should I or should I not implant? In this specific age group, we are worried about amblyopia. We are actually targeting this cataract at this stage because we want to combat the amblyopia. But then again, if you leave the patient aphakic, this is also amblyogenic. So you have to have a plan. If you are not going to implant, how you will correct or combat your aphakia. The recommendations for the IOL is that you should use acrylic lens, whether hydrophobic or hydrophilic. Square edge lens decreases the PCO. PMMA, if you are forced to implant in the sulcus. Heparin-coated lens, try very hard to implant in the bag. No silicone intraocular lens and no anterior chamber intraocular lens. The post-operative complication is that you may have a rather good surgery, but post-operatively, you're faced with excessive post-operative inflammation with anterior-posterior synechia. The IOL may become captured with pigment dispersion on the IOL and the back of the cornea. A PCO is very common. Certain types of uveitis, such as juvenile arthritis, is very common to get a membrane anterior and posterior to the IOL so that it becomes completely enveloped or cocooned within the membrane. Cystoid macular edema, epiretinal membranes, glaucoma, cyclitic membrane, and phthisis bulbi. The villains, just a few words about each type, is that the most common form of uveitis in the pediatric age group is juvenile idiopathic arthritis. These patients have poor prognosis after cataract surgery because of the exacerbation and reactivation of their activity. It is recommended by certain authors that you wait 12 months before implanting an IOL. The IOL, these are the typical types that become cocooned within their membranes. You should have to continue the pre- and post-operative immunosuppressive therapy, and sometimes intravitreal triamcinolone or steroid implants are needed. Fuchs patients are somehow in a low-grade activity throughout their disease course, but they do give good prognosis with cataract surgery. We fear mainly glaucoma and hyphema during the surgery. Behçet has a favorable prognosis, and this variable prognosis seems to depend on the posterior segment complication. So if the patient has a posterior uveitis, vasculitis, epiretinal membranes, optic atrophy, more likely that his visual prognosis is guarded. The frequency of attack tends to increase following performing cataract surgery, and therefore it is also advisable to wait like 6 months of inactivity before performing cataract. Vok-Krainagi Harada is very similar to Bassett. They give a good visual outcome if the posterior segment has no limitation. Toxoplasmosis, there's a small risk of 35% that you may reactivate retinochoroiditis, therefore prophylactic antihelminthic treatment, as with the parasitic granulomatous uveitis, which we've seen as a specific entity in Egypt. They do very good, and they give good prognosis after cataract surgery. Again, prophylactic antiparasitic treatment should be given. Herpetic patients, again, it seems that infective causes, you should give pre and post-operative prophylactic antiviral or antiparasitic, antihelminthic, and especially uveitic patients due to herpes simplex carry the risk of high FEMA. So in the pediatric age group, it seems that we are worried about amblyopia, we are worried about how we're going to combat the aphakia, and it is a lifelong disease, so the uveitis and the exacerbations and the increased frequency of attacks may be present, and therefore after you perform your surgery, the end of surgery is not the end of the story. Thank you.
Thank you, Dr. Rasha. Let me first tell you why I chose this subject. For a long period of time, لفترة طويلة جدا, I used to think that bilateral cataract, congenital cataract is the same disease as unilateral cataract. But lately I discovered, no, they are not the same. They are extremely different, and in many perspectives, this is what I'm going to talk about. This lecture in particular, identifying unilateral cataract as different from bilateral cataract, nobody ever thought of this and presented before. Why they are different? They are different, أولاً, infantile cataract is one of the most controversial topics in the field of pediatric ophthalmology. كلمة controversial يعني إيه؟ يعني فيها قيل وقال كثير. إيه controversies اللي موجودة in particular in the unilateral congenital cataract? الage مثلا. الage of operating the cataract. Some people would like to operate the unilateral cataract very early. Other people, they will tell you, no, this is a useless case. Keep it until later, and so on. IOL implantation. في schools بتقول إنه unilateral cases will go better with the contact lens. Other schools tell like, no, it will go better with the intraocular implantation. IOL power estimation is another debate in this disease, in this condition. People sometimes say go to emetropia, be close to emetropia. خلي قوة العدسة تبقى قريبة من الإمتروبيا. Others will tell you no, respect the variations اللي بتحصل with age. البوست operative visual rehabilitation زي ما هنشوف فيها خلافات كثيرة جدا. How to rehabilitate a unilateral cataract غير الريهابيليتيشن بتاعت البايلاترال cataract. والفاينل فيجوال ريزولتس مختلفين. Final visual results بتاعت البايلاترال cataract النهارده is fantastic. You can get very good results. أما اليونيلاترال cataract فلا. الاتيولوجي بتاعته ايه اليونيلاترال ده؟ اليونيلاترال cataract is usually an isolated sporadic condition. بيحصل كده. division، خطأ في الديفيجن أثناء الفيتال لايف في الفترة اللي بتكون فيها العدسة، كانت عدسة عدت very simply and the other one no. 86% of the unilateral cataracts and 68% of the bilateral pediatric cataracts have no cause. مش معروف لهم أسباب. وبالتالي المقصود إيه؟ المقصود ما تقعدش بقى تدور على أسباب فترة طويلة. الأجانب بيميلوا عندهم بروتوكولات في المواضيع دي. إنما أنا over the experience لا معنى لها unless إن في حاجة تبقى باينة خالص زي الجلاكتوزيميا أو so on. طب إيه الأسباب اللي عادة معروفة؟ الأسباب اللي عادة معروفة الهيريديتي. يعني مش ممكن تشوف أب لابس أفيك جلاسز زي كده ومعاه ابن جايبه عنده congenital cataract وتقول إن ما فيش جين هنا implicated. الميتابوليك كوزز اللي نعرفينها كلنا زي الجلاكتوزيميا صحيح الحاجات دي رير ما تتشافش كتير، انما لما بتبقى موجوده بتبقى باينه ودول بيبقوا ريكفربل ممكن يتعالجوا. الانترايوتراين انفكشنز اللي هم معروفين التورش الروبيلا وما الى ذلك دول ممكن يسببوا هذا اليونيلاترال كاتاراكت. والاسوشيتد كونديشنز احسن مثال ليها اللي قالته الدكتوره نيال في بدايه الجلسه اللي هو البي اتش بي في او البيرسيستنت هايبربلاستيك. البيرسيستنت فيتال فاسكوليتشر ده الاسم الاصح، لان as Dr. Nihal explained there are many items تحت البيرسيستنت فيتال فاسكوليتشر، ما هواش البي اتش بي في لوحده. It is the most common association مع unilateral cataract. يعني ايه المقصود بالجمله دي؟ when you see unilateral cataract احذر لا يكون فيه persistent fetal vasculature. في اختلافات في المورفولوجي كذلك. ليه؟ زي ما قلنا دلوقتي المحاضرتين اللي سبقوني unilateral cataract is isolated، هذا صحيح، ولكن it can be associated more frequently مع حاجات زي البي persistent fetal vasculature واللنتيكونس، وده يديهم مورفولوجي مختلفة، الشكل هيبقى مختلف عن حالة لاميلر كاتاراكت أو حالة كورونال كاتاراكت. اختلافات الاكزامينيشن أو الفحص، اليونيلاترال كاتاراكت عادة ما بيجو undetected والبرزنتيشن بتاعته بتبقى ليت، وهنا هيبقى فيه question mark على هذا الموضوع unless الليكوكوريا تبقى واضحة قوي. اليونيلاترال كاتاراكت إذا كان mild can cause irreversible deep amblyopia if not treated، يبقى هشوفه ليت وهشوفه amblyopia. The presence of either strabismus or nystagmus indicate a poor prognosis. مني أنا إليك، لو أشوف حالة فيها unilateral cataract أو unilateral media opacity cornea lens vitreous في طفل presenting with strabismus and nystagmus ابعد عنه. هدي الحد. fundus examination or B-scan مهم في الحالات اللي أنت مش قادر تشوف فيها posterior segment علشان نقدر نشوف الهايلويد سيستم زي ما قالت الدكتورة نيهال. الفيكسيشن بيهيفير والريد ريفلكس ار ابسولوتلي امبورتنت، بس خلي بالك من الفيكسيشن ريفلكس. بلاحظ ناس منكم بيدوروا على الفيكسيشن بيهيفير في الاطفال اللي هم اسبوع واثنين وثلاثه، ما عندوش فيكسيشن بيهيفير لسه ما عندوش، ما تدورش عليه لحسن تاخد امبريشن غلط تقول الولد ده مش شايف. فاذا الفيكسيشن بيهيفير عايز اكون عديت الاربع اسابيع اتليست. الريد ريفلكس is a very good test, very cheap test, very reliable test. هيوري لك اذا كان في obstruction في الميديا ولا ما فيش. في سكولز بالذات الامريكان يحبوا حاجه اسمها swept VEP في الاطفال الاكبر. swept VEP ده عباره عن VEP visual evoked potential، لكن يدي لك equivalent vision. دلوقتي بيتكلموا عنه كتير. المانجمنت استراتيجي مختلف ما بين البايلاترال واليونيلاترال. شوف لحد دلوقتي في اختلافات قد ايه. ان not all cataracts are visually significant، ممكن دول ما يبقوش لان ده حصل sporadically، الموضوع ده ممكن ما يبقاش visually significant. اذا كانت اللينتيكولار opacity دي موجوده في الفيجوال اكسس مش peripheral، it is usually considered visually significant لانها موجوده في المركز and requires removal إلا لو كان حجمها صغير. الكاتاراكتس اللي موجودة in the central of the visual axis and are lesser than 3 mm، يعني 1.5 2 mm، بتشوفهم بالريد ريفلكس بصعوبة سيبهم. أنا شفت أطفال كبروا ونظرهم 6 9 و6 6، don't touch it. لازم يبقى central axis ولازم يبقى كبير. قالوا 3 ملي، 3 ملي انت تقدر تعملها in proportionate with the size of the iris. ليه؟ ايه حكمة الناس اللي they operate اليونيلاترال كاتاراكت؟ انا لما كنت نائب كان استاذي يقول لي اليونيلاترال كاتاراكت ده inoperable. ليه الناس دي بتقول كده؟ وايه وجهة النظر المضادة؟ وجهة النظر المضادة ان two eyes will give you a larger field مثلا. نمرة 2، إذا كنت أنت شاطر if you are successful in the treatment and management of this case, you did a good surgery, you did a good post-operative management، وبالتالي you will end up with a fascinating advantage اللي ربنا اداهولنا اللي هو الباينوكولار ستيريوبسيس. binocular vision and stereopsis دي خدمة إلهية اداها للإنسان. if treatment is early and efficient يبقى الموضوع يستاهل المحاولة. هل للإيرورز اوف ريفراكشن دور هنا؟ study اتعملت مشهورة جدا هذه الاستادي، اتعملت في ويلز اي هوسبيتال، وقالت ان الاطفال دول بيبقوا امبليوبيك حتى من الاوباسيتي الصغيرة اللي بتغير الريفراكشن. فبالتالي لما تشوف حالة unilateral cataract you have to do a good retinoscopy علشان even one diopter can render him amblyopia, and in this case you cannot blame the cataract, you blame the refractive error that induced the amblyopia. المانجمنت starts with the conservative management. conservative management 3 حاجات: spectacle, spatching, dilatation. spectacle ما لهمش دور هنا. الباتشنج والدايلاتيشن قصتهم ايه؟ You can dilate the pupil إذا كانت الأوباسيتي في visual axis and small and you want to dilate the pupil a little bit، استعمل أتروبين مخفف 0.5%. لكن هذا التكنيك عيبه بيليمت الفايدة بتاعته انك انت you are abolishing the accommodation وفي نفس الوقت you are rendering this child photophobic. طب what about patching؟ في هذا الموضوع 3 أنواع من الباتشنج لا تنساهم. نوع جديد عليك أنا عارف إنك ما سمعتش عنه، بيستخدم حاليا بكثرة، اسمه full time binocular light occlusion. إيه ده؟ طفل اتولد، هذا هو السيناريو اللي منطبق عليه. طفل اتولد، بيعملوا هم هناك سكريننج أول ما يتولدوا بالريد ريفلكس، النيرس تعمله في غرفة الولادة. عملت لقت ان في يونيلاترال كاتاراكت، قالت للاوفثالمولوجيست. الاوفثالمولوجيست اول حاجه عملها ايه؟ عمل باتش على العينتين. ازاي في حد يباتش العينتين؟ لان during the first months دي الفتره اللي بيحصل فيها الفيجوال ديفلوبمنت الاولاني بتاع العين، فهو عايز يوقفه علشان ما يحصلش disparity ما بين العينتين. بتكلم على اليونيلاترال كاتاراكت. فعشان يعمل كده عمل ايه؟ وقف الماتوريشن اوف ذا فيجوال سيستم. يقدر يوقفها لمدة قد ايه؟ ماكسيمم لمدة أسبوعين على ما يوبريت، وبالتالي في الحالات دي محتاجة early surgery. في نوع تاني اسمه البارت تايم. البارت تايم ده بيتعمل في الحالات اللي اتعملت في الوقت المناسب عند 4 أسابيع واتعمل لها ريهابيليتيشن كويس with the contact lens. عايز تعالج الامبليوبيا اعمل بارت تايم اوكلوجن مش فول تايم. بارت تايم يعني نص الوقت اللي هو صاحي فيه الطفل. الفول تايم اوكلوجن تيجي امتى؟ للحالات اللي فيها سترابيزمس او نستاجمس. السيرجيكال مانجمنت بيدور حوالين ايه؟ لينزكتومي او ايريجيشن اسبريشن، يعني فيكو اسبريشن او ايريجيشن اسبريشن. انا بفضل الايريجيشن اسبريشن عن الفيكو. ما معنى ان انا ادخل حاجه كبيره كده انسايد ذا اي وانا اقدر اخلص الموضوع من خلال الباي مانوال سواء with أو without an intraocular lens، دي قصة تانية. الانفنتس اللي أصغر من 6 أشهر اتعمل لهم كاتاراكت، it's better to fit them with contact lenses. ما اتكلمش على هنا الثيرد وورلد ما يقدرش يعمل contact lenses، إنما أصول الطب ما يعرفش ثيرد وورلد وبرايمري وورلد، يعرف الأصول إيه؟ الأصول لو هو يونيلاترال وسنه أقل من 6 شهور أحسن حاجة له يا سيليكون يا إما أن تكون جاز بيرميبل لينس. طيب لو هحط عدسة، هل لازم من الشياكة ان هذه العدسة تبقى هيدروفوبيك اكريليك؟ لا، لان عملوا ستاديز لقوا ان الاثنين ليهم نفس الريت اوف كومبليكيشن. يبقى لو ما عندكش دي ممكن تستعمل دي. البوست اوبراتيف تارجت ريفراكشن انا اميل طبعا انه يكون ناحية الاميتروبيا. الاوبتيمال ايج فور يونيلاترال كاتاراكت سيرجري 4 ل 6 أسابيع لو اتشخص كويس to avoid السنسيتيف بيريد اللي بنتكلم عليها دي. ليه مش قبل 4 أسابيع؟ الانسيدنس بتاعت الجلوكوما بتبقى أعلى، اللي هي هم عندهم مشكلتين كبار الناس دول الأطفال دول، الجلوكوما والمايوبيك شيفت، والاثنين ملعونين في تشخيصهم وفي علاجهم. وبالتالي إذا كان في حاجة بسيطة زي إنك تستنى the 4th week استنى. الأولدر تشيلدرن بقى اللي فيه ديبيت، اللي كان أستاذي أنا قال لي ما تعمل لهمش، دول إيه وضعهم؟ They can be operated only if the cataract is partial and not associated with strabismus. لو الكاتاراكت كان dense ما هلاحظوهوش جايين من أرياف and so on و associated معاه latent nystagmus أو معاه strabismus don't operate him. الفيديو ما أعتقدش إن عندي وقت أعرضه لأن أنا بستعمل اهدى شوية. أنا بستعمل البوش بول تكنيك بتاع نيتشل، وصفه هو من 15 سنة. ده تكنيك كويس جدا، ما بيعملش اي اكستنشن للكابسولار اكسس. الريهابيليتيشن افتر سيرجري بقى ايه وضعها؟ الانفنتس will need continued monitoring. كلمتين دول مهمين عندي. continued يعني على طول على طول على طول، monitoring يعني اعادة كشف. ليه؟ للامبليوبيا، للريفراكشن، للباتشنج، لظهور الاسترابيزمس. مش الاسترابيزمس الموجود. الاسترابيزمس الموجود دي حاجه مش كويسه، ده فيري باد بروجنوسيس. ولو عملت له سيرجري فور ذا استرابيزمس هم دول اللي بيحصل لهم ريكارنس. فبالتالي انت يو هاف تو فولو الريفراكشن والموضوع الباتشنج اند سو اون. بختم كلامي بستادي مهمة جدا من المايل ستونز بتاعت جراحة عيون الأطفال، اللي هي EAPOS، اللي هي الانفنت افيكيا تريتمنت ستادي. دون الدخول في تفاصيلها كثيرا، عملوا 2 جروبس، جروب حطوا له انترا اوكيولار لينز وجروب تاني لبسوه كونتاكت لينز، وعملوها على 12 سنتر، يعني حاجة محترمة. لقوا ايه بقى؟ لقوا ان مفيش statistical difference في الفيجوال اكيوتي لما الاطفال دول كبروا. اللي حطوا كونتاكت لينز زي اللي حطوا انترا اوكيولار لينز، فما تتباهاش قوي باستخدامك للانترا اوكيولار لينز، لانه you can reach the same thing through a contact lens. طبعا بتكلم على اليونيلاترال افيكيا او سودوفيكيا. Thank you very much. اشكركم.
السلام عليكم، متشكرين جدا للتيم كله. حقيقة انا اتعلمت كتير النهارده، لكن كان ليا سؤال. هل في اكسبيرينس في سن اكبر شويه؟ ما اعرفش التشايلد بنقول عليه لغايه سن كام سنه؟ التشايلد يبقى لغايه سن كام سنه؟ 6 بس؟ طيب do you have any experience from premium IOL for bilateral cataract like toric IOL or multifocal or trifocal IOL?
No, I don't think I will ever use it. Impossible to use a multifocal or
What is the youngest? Do you have any experience? What is the youngest age to have these lenses? No, not congenital, maybe, or light congenital cataract, not so dense, and at the age of 10 years, 15 years. Is it recommended or you don't have?
As I know, I don't have experience, of course, in senile cataract, but I know in these cases في بعض الناس إن هم they are not satisfied with it. فما بال حضرتك بالinfants and children. I don't think it's going to be in the future. At least me, I don't have the gut to implant a multifocal intraocular lens in children.
Thank you.
Thank you very much. شكرا جزيلا.